Thank you, Abraham and Jonathan, for the invitation. Thank you to Daniel Yang and the Moore Foundation for taking up diagnosis as a major effort. And so I'm a dermatologist, and I'm the CEO of Visual DX. About 10 years ago, I gave a talk to internal medicine at Emory University, and I met Ken Walker, an internist and a neurologist, who said to me, after I told him that I had worked with Dr. Larry Weed in the 80s, he said, "Art, I have something for you that you'll want." And he handed me a CD-ROM, and I got back home and put it in, and I realized at that point that I had discovered the original TED Talk. And this was a TED Talk before there were TED Talks. So I'm going to play a minute, and during my presentation, I'm going to come back to some of the themes here.
If you can't evaluate what you're doing, then there's a very serious possibility that you do not know what you're doing. Now, what I'm saying is that a doctor has to be a guidance system. He is not an oracle that knows answers. And once he accepts the concept of being a guidance system, then he knows that the data system is the basis from which all his work must take place. And good medicine is a careful, rigorous inching your way towards a more and more secure position. A final diagnosis is a myth.
Maybe there's something wrong with the way we're running the whole operation. Memorize, regurgitate, forget. Memorize, regurgitate, forget.
There's 500,000 deaths a year from mistakes in medicine. Where's the outrage?
So the theme of this talk is really summarized by this equation, that the brain plus computer-based information is more powerful than the brain alone. And with the exception of oracles like LT and Gurpreet Dhaliwal at UCSF and other masters in diagnosis, I really want people to think about that nurse practitioner seeing a patient in retail care or a family physician out in a rural area that's seeing 20 patients a day. And so the idea is that machine learning, artificial intelligence, rules-based systems, all these systems that help us improve our thinking are all just forms of computer-based knowledge. And when we started working on Visual DX, close to 18 years ago, I said to the co-founder, Lowell Goldsmith, who was the dean of the medical school, "I can't get the residents to use these systems." And he said to me, "I can't get the residents to look up in the book." And so really the question is, can we mobilize information at the time of decision making? So Mark did a great job of summarizing the problem of diagnostic errors, and we created an iceberg infographic that shows that diagnostic errors have been below the waterline, and other speakers here have highlighted how many diagnostic errors there are a year. And we created another infographic based on data just 2 weeks ago published by Coveris, a leading liability insurer. And they said that 33% of their closed claims for malpractice were diagnosis related, and 24% were in the emergency room, and 36% were in ambulatory care. This book was mentioned by Eric as well, Thinking Fast and Slow, and Mark touched on cognitive mistakes in the work of Pat Croskery, who's written many great papers on the reasons doctors make mistakes in their thinking, such as premature closure, anchoring, overconfidence. We've been really interested in this cognitive mistake representative bias. And so the idea is that patients come in with common things happen commonly. If you hear hoofbeats, think horses, not zebras. But variation of the common also happens more commonly than we think. And so I think Mark mentioned there are 10,000 diagnoses, but in your lifetime as a primary care physician, maybe you see 400 or 500. And yet there are mistakes with the common. So if you study the closed claims of why doctors are sued, the top 4 are lung cancer, breast cancer, colon cancer, and prostate cancer. And then you have missed MI, missed cardiac events, missed stroke, missed PE. They're all diseases that everyone in this room knows. So why do doctors miss diagnoses that we all know? And one reason is representative bias. So the first graphic is a 67-year-old with toothache and fatigue. So this was mentioned to me by an ER physician that told me the story of a patient that came into their emergency room and was triaged over to the non-acute side because the patient complained of a toothache. Hours later, they discovered the patient was having a myocardial infarction. So for the non-physicians in the room, you can have atypical presentations of a common diagnosis like myocardial infarction. The next one says 45-year-old diagnosed with Bell's palsy. And the physician never asked the question, what could be the cause of the facial droop? And it turned out it was Lyme disease that was misdiagnosed, and they didn't push further to ask the question of why. And last, I'm borrowing a story from Lisa Sanders, who writes for the New York Times, who had one of her cases just a couple of weeks ago, a 35-year-old with spontaneous pneumothorax, where the physician didn't ask the question of, was it happening around the time of the menstrual periods? And these were spontaneous pneumothorax related to the period because of endometriosis. So as physicians, we look for prototypical classic cases, and we're frequently fooled by variant presentations. And so when you start to amass lots of cases, as we do at our company, we look at cases of photos, and I'm a dermatologist. I'm going to speak to some dermatology examples, but there's a diagnosis called fixed drug eruption. It's actually a very, very common diagnosis, and you get a patch that recurs in the same body location each time you take a PRN medication. And the reason they're common is because non-steroidals like ibuprofen and naproxen can cause fixed drug eruptions. And by aggregating all these cases, we started to realize that fixed drug eruption, which the literature says classically occurs in the mouth or on the genitals, actually had localization to the web spaces. And so we started to see these patterns by just aggregating lots of cases and beginning to understand that what we teach the medical students and residents to memorize might not be as common as we think it is. So we created this infographic to kind of highlight what a physician has to do. And Dr. Weed said, physicians are not oracles who know answers. But when you think about what a busy clinician does, say an ER physician, they have a tremendously difficult job in the emergency department, having to know all of medicine. So patients come in with complaints like chest pain, breathing difficulty, heartburn, depression, and the research shows out of 20 patients, 2 will be wrong. So in the infographic, we have headache, and it says diagnosed tension headache, did not realize workplace exposure to carbon monoxide. So this was an interesting one for us because at our company, in our prior office, we had employees that had headache. And our office is backed up to a warehouse where they ran propane forklifts. And there was space between the warehouse and our offices where it communicated this carbon monoxide. And we had employees with headaches that went to see their physician. And it took about a year for us to figure out why these employees were having headaches. And so, the physician would have to know to ask the question about carbon monoxide exposure and not just triage on what are the most common causes of headache. So we tend to do what's efficient. We ask the questions about what we know, not the questions that we don't know. And the other one is diagnose benign positional vertigo, miss to cerebellar stroke. Example of premature closure. So how did we get here? So this is a medical record before computers. And so everybody looks at this and say, well, it's illegible, right? So back to Dr. Weed. So Dr. Weed didn't come along and say the medical records are illegible. He came along and pointed out that the medical records have no structure. And so he proposed this idea of the problem-oriented record and SOAP notes. And I think it was Mark that pointed out that people are not taking care of their problem list. In fact, most of my residents don't even understand the problem list, because Larry Weed said that problem lists should include problems. So the patient comes in and says they have diarrhea or they have shortness of breath. You don't put the diagnosis in the record until you have a basis for saying that they have a diagnosis. But the records encourage us to prematurely close. So here at Stanford, I'm wondering by a show of hands, how many of the clinicians have seen in the EHR unexplained vomiting, unexplained headache? In our tertiary care hospital, I hardly ever see in the problem list unexplained symptoms. So if the problem list is just a list of the past medical history, that's basically saying we know everyone has a diagnosis, which can't be true if we know 10% of diagnoses are wrong. So we haven't really followed what Dr. Weed was recommending when he wrote this 1968 paper in the New England Journal called Medical Records That Guide and Teach. So how many people here think the electronic record guides and teaches? I don't think so. I don't think many people think that Epic or Cerner or any of these records are guiding and teaching. And so he came up with the problem list and SOAP notes, and it really was the first checklist. I mean, the SOAP note format was saying, here's a structure to guide your thinking in medicine. And it really was revolutionary, and unfortunately, we've gone backwards. So Weed railed against this paradigm of that you can just be a medical student, read during residency, see patients, and put it all in the brain and be flawless every 9 minutes, as Eric said, how much time we have for patients. So here's the 60s. We had another photograph earlier of a physician smoking. Here's someone working with their electronic record with a stogie in the 60s. And here's Dr. Weed in the 70s. And remarkably, he forced an entire floor in the Fletcher Allen Hospital in Vermont to be computerized, demanding that the surgeons did physician order entry in the 70s. It did not work out well. So he was sent packing, and around the same time in the 80s, these other systems were developed. And so Internist One is a diagnostic support system that was founded by Jack Myers in Pittsburgh, Iliad by Homer Warner in Salt Lake City, D-Explain by Octo Barnett, and Problem Knowledge Couplers by Larry Weed. And this is a screenshot of D-Explain. And at the center, you see it has case findings. It says sheep exposure, fever. You put in the patient's findings, and on the right, it gives you a differential diagnosis. And this is pretty much the format of diagnostic support over the last 40 years. So what do most physicians use? They use this. And so we created this slide, and I asked you, would you fly on this plane? I don't think you'd get on this plane. And so pilots have a cockpit with instruments designed for flight, for takeoff, flight, landing, and taxiing. So tools have been developed to match the information needs of flight. So we need a cockpit for professionals and for patients. And it's my belief that they're not a consumer system over here and a professional system over there. We really believe there needs to be a knowledge base and a platform that spans the patient and puts the patient at the center and then can move data over to the clinician. So we've been working on this since 1999. And we started by saying we need good terminology. So we started working with SNOMED and the concept-oriented terminologies that your informatics department knows all about. And we started to build a knowledge base, and we started collecting images back when we had this stuff called film. And we had this company in our town called Kodak, which none of the residents and students ever heard of. But so we've been purposely collecting professional medical images for close to 20 years and tagging those images. And then we've hired librarians and physicians to build a knowledge base. And so there's hard wiring. So this is not big data AI. This is really looking at the findings as they relate to diagnosis. And so we think that diagnosis, at least at the foundation, is not a big data problem. There aren't millions of diagnoses. As Mark said, maybe there's 10,000. And each diagnosis has symptoms, signs, lab, travel, medications. It still does not add up to big data. So we started building this knowledge base, and then we created this visual interface with the idea of, can we create an interface that handles variation in presentation? And then we were really excited to learn about this thing called machine learning, because people were asking us, even 10 years ago, hey, Art, when can I point my phone and it will analyze the rash? And we said, that's like 20 years away. And along came Café and TensorFlow, and we had some engineers in Rochester said, this is cool stuff, we can do this. So we started training the model on our images, and we had built this image database and not only put the diagnosis name on the images, but we put other data on the images, like the type of lesion in the image. It's a vesicle, it's an ulcer, it's an eschar, and it's on the leg, and it's a skin type 1 or a skin type 6. So we had all this data in the database, and Café and TensorFlow came along, and we developed this model where you could take a picture on a phone, send it up to the cloud, and we'd analyze the picture and send it back. So we brought the machine learning and this knowledge base together in this product. And what's unique about this is trying to create a visual interface. So in the upper left, you'll see that laundry list of a differential diagnosis. So historically, we've given busy physicians a laundry list of a differential, which means if they don't know the diagnosis, they have to click it, read about the diagnosis, go back in the browser, read another one, keep going back and forth and trying to hold all those relationships in the brain. So we came up with this interface where we represent diagnoses with photos if there's a skin rash or radiographs, but then we also started to create these diagrams in the upper right that we call sympticons for symptom icons. So the idea is that when we were memory-based, we create these textbooks where we say, students read, and then we'd illustrate the text with a figure. When we flipped it around, we said, let's make the figure first, and let's illustrate the patterns of disease, and then you can go read about the disease and compare. And then the other feature, and this is also borrowing from Dr. Weed, is that in the top it says workup for facial palsy, and on the right it says workup for blanching patch. And this is an illustration of handling variation in an information system. So Lyme disease has many different presentations. So classically, Lyme disease presents with a bullseye-shaped expanding erythema, but certainly a patient can come in 6 months later, miss the fact that they had a rash or the rash was never developed, and now they have a neurologic symptom. They have a facial palsy. And so what our interface does, it accounts for that by putting up in the differential either a picture of the rash if the clinician searched by a rash feature, or alternatively if they said facial droop and arthralgias, because we did not search by a rash feature, it flips these sympticons to the diagram that matches the phase. So you could have an early Lyme disease where you have facial droop and arthralgias. You could have chronic Lyme disease where you have paresthesias and other neurologic symptoms. So we've created multiple sympticons and lots of images, and the system is trying to find you the match of the phase of the presentation that's before you. So what's the role of AI in decision support? And how do we use machine learning to enhance skills and to not de-skill? I think this is one of these challenges with all AI. There's this concern that we won't pay attention while the self-driving car is going, or the pilot is over-relying on the instrumentation, is losing some of their skills. And so this is a picture of Dr. Inga Rousey, who's a pediatrician who has our app. And this is a really fun case because I received this photo on Thursday, and I then texted Dr. Brian Brown, who's the chair of emergency medicine at the University of Maryland, to ask him if I could use this picture during this talk. And he said, sure. And so this is a woman that presented in Baltimore last week to the emergency room. She's a 66-year-old female with a 2-week history of enlarging lesion, which she told Dr. Brown that she had taken a string around it initially and ripped it off. And then it came back even larger within a few days. So quickly enlarging lesion. And so he had Visual DX with the machine learning on his phone. And so he took a picture. That's on the left. It's a snap a picture. And then it brings up in the bottom, it's probably hard to see from the back of the room, 3 skin morphologies. And the first one is friable papule. The next one's ulcer. The next one's skin erosion. So what we trained the machine learning to recognize the skin exam features. We're not going directly to diagnosis. So the need is that non-dermatologists look at a lesion or a rash, and what do they call it? They call it a rash, which is like if it's raining outside, you're saying it's humid, or it's snowing, you're just saying it's moisture. So rash is vague, and rash does not help you get to a diagnosis. So what we're trying to do is use the machine learning to actually guide and teach. We're putting up at the bottom of the screen the words that every medical student that graduates from this university should know. But I know at our medical school, where I've taught this lecture for probably 15 years, where I say to the medical students, the fundamental part of doing diagnosis from the skin is being able to describe what you see. And I'll get a review from the medical students that say, too basic. And then I'll say to them, well, last year they said it was too basic, but why do 50% of you graduate not knowing how to describe the skin exam? Well, important. The patient loved this experience. So Dr. Brown said, patient loved the attention. Quote, I also explained what I was doing, a running commentary, thinking out loud as I did it. She loved how this app worked well. And this ties in to the need that we're trying to address. So this is an infographic. As I said, medical students get very little training in the skin exam and dermatology, yet 65% of dermatologic or skin-based questions are not seen by dermatologists. They're seen by primary care, the ER, et cetera. Yet with these problems, there's only about 48% accuracy by primary care and ER doctors. So this relates to Core ML. How many in the room have heard of Core ML? So we took our model and we adapted it last summer and fall to put the machine learning on the iPhone. And this was really remarkable for us around the 2 issues. One was patient privacy. None of our clients liked the idea of their physicians taking a picture of a patient's face and sending it to visualdx.com. And so with Core ML, the model's on the phone, the physician takes the picture gets dumped after it's analyzed, and VisualDX never sees the photo. The other thing it accomplished is all that computing happens on the phone, and we don't have to have larger servers to handle all that data of analyzing all these images. Another important theme in our experience with decision support is actually that patients like decision support if you talk to them and you use it with them. So there's a conflation of the EHR with healthcare information technology, which I think is unfortunate. What radiologist or orthopedist wants to go back to plain films that you're hanging? I mean, I certainly been to an orthopod that swiveled the monitor and showed me their digital images. That's advanced care enormously. How many physicians hated Hippocrates or hate Hippocrates? I mean, it's so much better than going down the hallway and getting that thing called the PDR. And so we've had all this advance in health information technology that's completely crowded by the disappointment of the EHR. And so people will say to me, well, Art, if Visual DX is not in the workflow, people won't use it. And what we've discovered that the workflow and thought flow is not only the EHR. Mobile devices are part of many physicians' workflow. ER physicians in particular, hospitalists, they're often walking down the hallway, grabbing their phone to look for dosing, looking for information. So we have a lot of our users using Visual DX on a mobile device like this physician and just teaching the patient with it. And so, if patients are on Google, they're on WebMD before the visit, they often come to us with printouts from the internet. And Dr. Topol said something like 9 minutes we're spending with the patient. How does the patient really know when we give them so little time that we actually do know? So 80–90% of the time we know. It's simple, it's common. But how does the patient know that we really know in this world of them spending an hour or two on the internet before they come to see us? So part of the answer, I believe, is doing these searches in front of your patients. Demonstrate that you care. Look up information about the presentation with them. I've had this happen multiple times in clinic with the residents where a patient says, I believe I'm having a medication reaction. And I know that the reaction they're complaining of really is not real. But what I do is I go search the medication in front of them, and we look at the screen together, and I say, it's not a cause of your symptoms. And what that transmits to the patient is that I paused and I actually looked up something on their behalf. And this is a sea change from 20 years ago when we started, or from 25, 30 years ago when I started in medicine, where physicians would say, I never look anything up in front of the patient. It will show the patient that I don't know. And I think that's a really positive change where the patients are looking up information, and it's forcing us now as clinicians to look up information. So we actually will do these searches and show the patient what the differential diagnosis process is. And we use the imagery to calm a worried patient. There's nothing like a patient seeing a photo. If you shoot those Latin words at the patient, they hit the parking lot, they don't remember what you said to them. But if you turn around and in the case of dermatology, you show them a photo, it often just calms them and soothes them. So what's next is we've been working on a new project off our database for the patient themselves. And the idea is that you can be predictive about the questions that you can ask a patient at home or on their mobile device. And we envision a day not too far in the future where you're talking to Siri or you're talking to Alexa, and you say, I'm having difficulty swallowing. And your phone knows your age, your gender, it knows your past medical history, it knows the medications you're on, and can actually start asking you questions back in context. And then after you complete those answers, we move that data over to the professional. So one ecosystem, so this slide has on the left, it's probably too hard to see in the back, consumer terms like aching joint and heart racing, and then arthralgias and tachycardia on the other side. But what you need is you need a platform that spans the patient to the professional. And so this patient co-pilot that we're working on is called ASA, and we're starting with skin, and then we're going to move towards other chief complaints, just like we did with Visual DX. So in summary, we really think that AI is just part of this category of decision support, and that the AI is going to be used by clinicians and patients, and we need a single ecosystem. And if we can start driving better decisions around what's the most appropriate, safest test to order in this decision-making moment, what is the most appropriate, safest therapy, cost-effective therapy to order, then we'll really start getting at the essential questions of medicine. Thank you.
Thank you so much, Dr. Papier. A really great review of all the different potential and some very cool technology available. which some of that technology you've been working on for 20 years, basically, and DXplain and Isabel. But it was, again, how come that doesn't seem to be used that much? In some cases, you might even provide that technology to doctors for free, and yet free doesn't seem to be cheap enough.
Well, it's a great question, and we lack feedback loops, so our clinicians think they're a lot smarter than they really are. I mean, let's be honest, if you have a 10% error rate, what physician says to you, you know, I blew it on 2 patients today, and they say that every day? No one says that. So clinicians don't know what they don't know, and we've had this educational paradigm loaded to the brain, memorize classic disease scripts, and we don't really understand that even for common diseases, how many mistakes we're making.
I think a great segue to Fei-Fei Li is going to come up just now. I feel like a lot of the real revolution in image recognition has been the creation of the data source, right? Your labeled images and how much can we automatically extract from that. I guess one thought, you want to keep privacy, right? You don't get access to those images that somebody took on an Apple phone, but in some sense, isn't that so much valuable information that we're not taking advantage of? We're losing the potential for institutional memory, and is that just something you have to accept, or some way to reconcile the value of everyone's data while keeping it private and secure?
I think that's the role of the patient directly with technology, that instead of going through the institution and through the EHR, when patients start to use these tools, we'll be able to start to mine their directly information from them.
Got it. Very good. Lots more, obviously, we can discuss. I do want to keep us to the next schedule. Dr. Fei-Fei Li is next. Thank you again so much, Dr. RPPA, and look forward to chatting further.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.